Hello and welcome back to yet another PhysioTV classroom session. I am Dr. Riya Gondari, Assistant Professor at Sancheti Institute for Orthopaedics and Rehabilitation, College of Physiotherapy. Today I am going to talk about maximal inspiratory pressure, outcome measure in pulmonary function. So let's get started with the objectives. The objective of this session is to define maximal inspiratory pressure, also MIP, understand physiological basis of MIP, highlight the clinical relevance, discuss methods of assessment for MIP, outline normal values and influencing factors, and understand the limitations and interpretations. So let's start by understanding what is MIP. So the greatest pressure that is generated during maximal inspiratory effort against a closed airway is called as maximal inspiratory pressure. It indirectly reflects the strength of the inspiratory muscles, primarily the diaphragm and the intercostal muscles. Let's start by understanding what is the physiological basis for maximal inspiratory pressure. So inspiratory muscle function is crucial for maintaining effective ventilation and preventing respiratory failure. The primary muscles of inspiration, that is the diaphragm and the external intercostal muscles, help to generate a negative intrathoracic pressure by contracting against resistance. Now, this inspiratory pressure is what is important for us to know on the basis of which we can evaluate the patient. So this maximal inspiratory pressure is measured at reserve volume to evaluate maximal effort. Now let's understand why reserve volume is important. So reserve volume is nothing but the maximal expiration that happens, and at that moment the amount of volume that is reserved inside the lungs is the reserve volume. Now during the reserve volume, what happens is the muscles that we talked about, that is the diaphragm and the external intercostal muscles, are at the shortest length. When the muscles are at the shortest length, they take maximum force to bring about maximum pressure generation inside the lungs. And hence, since we are trying to look at the maximal inspiratory pressure, so it is measured at reserve volume. Let's look at the clinical relevance of using MIP. So it is usually used in respiratory diseases, for example COPD being one of the most common ones, because of the progressive hyperinflation that takes place in conditions in COPD, a lot of the times the diaphragm's function is inhibited or goes into a dysfunction. For that matter, we try to assess MIP in respiratory diseases. Then coming to neuromuscular disorders such as myasthenia gravis and DMD, which have a lot of respiratory involvement, especially the diaphragm again. So in these cases also, MIP is a crucial factor in understanding the strength of the inspiratory muscles. Then again, diaphragmatic paralysis, be it unilateral or bilateral. In these cases also, the MIP might be reduced, so it plays as a crucial factor again. Then in terms of critical care, we often, when the patients are on a ventilator, MIP is seen as a important criteria for weaning a patient off of the ventilators. So they are considered that negative pressure of 30 centimeter H2O is considered as the weaning criteria for any patient. And then when we talk about rehabilitation, it helps us to prescribe inspiratory muscle trainers. Along with that, also understand if the physiotherapy rehabilitation that we are going for is effective in a patient or not. Coming to methods of assessment, so there are two types of manometers which can be used. Either it can be digital or analog, which are going to help you understand what the maximal inspiratory pressure of a person is. So talking about the methodology in which it is done. So first the patient is asked to sit comfortably, after which a nose clip is placed on the nose so that there is no air leakage through the nose. And then the person is asked to expire maximally and completely so as to reach the reserve volume that we already talked about. After that is done, we need to place the mouthpiece that you can see here in the digital manometer, the blue piece. It is placed in the mouth in such a way that the lips are sealed against the mouthpiece and there is no air leakage. And then the patient is asked to inspire as long as they can. And the similar technique is used also for the analog manometer. Usually a reading of 3 is preferred, and then a mean is taken of it. Talking about the normal values, so in males the normal value is 75 to 130 centimeter H2O, and in females it is 50 to 100 centimeters of H2O. The influencing factors for this are age. In age, as the age progresses, because of the natural physiological changes that happen with this muscular system, even the function of the inspiratory muscles is declined, and hence the MIP can be seen reducing as the age progresses. Then comes to gender. Because of the muscle mass that is present in males is higher than the females, so similarly the MIP values will also vary. Again, the body position, literature says that the MIP values are higher when sitting or standing as compared to lying down or being in supine. Again, lung volume, so depending on the pathology present in a person or the condition that the person has, or the innate lung volume differs from person to person, and hence the MIP values can also vary. Interpretation. So decreased MIP values are seen in inspiratory muscle weaknesses and the possible conditions in which it is seen as COPD, diaphragm paralysis and neuromuscular diseases. The rationale I have already spoken about earlier. Then talking about use in monitoring, so it helps to assess the disease progression and hence also understand if the physiotherapy protocol that we are giving or rehabilitation that is being given to the patient is effective or not. Let's understand the limitations of using MIP. First of all, it is effort dependent, which means if the patient is not able to generate the maximal inspiratory pressure effectively, or is not able to perform the assessment properly, the MIP readings might differ. Again, second is learning effect. So as I said that it is mostly patient based, or the pace of the assessment is more dependent on the patient's efforts. So if the person is doing it for the first time, might not be able to do it correctly, but as the patient learns the technique, the MIP values will again start differing as they get the skill of performing the assessment properly. Technical factors, like in such cases, if the pressure gauge or the manometer as we call it is not functioning well or has some leakages present in them, in that cases also the MIP readings might vary. Age related decline, like I've already talked about earlier, that age is an influencing factor when it comes to maximal inspiratory pressure. Applications of this is, first it's used in inspiratory muscle training. Whenever we need to prescribe an inspiratory muscle trainer, MIP values are helpful in determining at what level do you need to start the training. Same again with ventilatory weaning, as I've already said, a pressure of minus 30 centimeter H2O is mandatory for having or starting the weaning in a ventilator in a patient. And third, as we are talking about MIP as an outcome measure, it is very much helpful in research projects as well. These are some of the references. Thank you so much. I would like to thank the management, principal of SIOR COP, Dr. Apurva Shimpi, and the Physio TV technical team, Dr. Fareen Patel and Dr. Shivani Chutke, for giving me this opportunity to have a session on Physio TV. Thank you so much.